I'm Dr. Michael DeTola.
And I'm Megan Strong.
On today's Case of the Week, digital technology gets us about halfway where we need to be.
And in the news, just another reason to probably get that second opinion at the doctor.
And a well-meaning dentist writes us a great letter with a great tip, and it spawns toaster oven mania. That and more on today's Chairside Live. Hey now, hello and welcome to episode 143 of Chairside Live. Megan, how are you?
I'm doing well. How are you doing?
I'm doing all right. Did you you got a chance now to experience some barbecue from a couple different places in Texas? I don't want you to pick a favorite, but in general, are you at the point where you can say that Texas barbecue far ahead of California barbecue?
I mean, there's not even a question.
Right.
There's not even a question. I've been to a ton of barbecue places here in California, and I think that any Texan would laugh at them.
Yeah, and you weren't even experiencing, I mean, to really experience Texas barbecue, we'd have to take CSL on the road and go film in Austin, maybe, or film in a couple different places.
Sure.
Because you were having it frozen and then thawed and reheated. That can't be the best way to enjoy barbecue, I'm sure.
There's no way. But even with that, having it, been frozen and shipped and whatever, it was still amazing. So I could only imagine what it would be like, freshly smoked right in the restaurant and then, served to you minutes later. But, oh gosh, now I'm hungry, thanks.
Texas Dental Association, maybe next April, next May, we go on the road, set up a little Chairside Live table in the Glidewell booth and have it be the all barbecue issue.
Don't tempt me.
All right, well, we'll see. We may make that happen. We got an interesting case of the week for you today. It's kind of the promise of digital technology that I've been referring to. This has been the summer of CAD CAM as far as I'm concerned, and I'm trying to share different perspectives on digital technology with you. And this is going to show a case where it takes advantage of some parts of digital technology, but not some of the ones that I feel are the most important. And we're kind of left in a difficult position with this doctor. In fact, let's go ahead and take a look at that case now. Today's case is a doctor who has taken a digital impression with his Lava COS scanner and would like a Bruxer solid full contour zirconia bridge from teeth number 29 to 31. And the doctor has the option to request the bridge in the model, I should say, in the software itself, and has requested a model for that, which we obviously want when we're making a bridge. A little different than a single unit where we still like to have a model to be able to work with. And so 3M has, as you can see, some partners that they trust to print their SLA models. These are laboratory partners that have been verified as doing a good job for them, and they know that it's going to be accurate. And so this is what an SLA model looks like that you would receive from a 3M trusted partner. And this is printed on a 3D printer. So unlike maybe the CAD model, if you've seen those, they're kind of big and heavy models that are milled from polyurethane. These are printed on a 3D printer. So if you've seen the way that we fabricate Emax crowns currently, we will use a 3D printer to print a full contour crown, invest it, burn it out, and then press Emax into it. This is the way Sirona makes their models through Infinident, the same way, 3D printing. And if you use our ClearLock product, where we will send you essentially orthodontic retainers or Essex retainers. We'll send you 3 upper and 3 lower, and if the patient loses them or the dog eats them and you need 3 more, this is what we do. We take that stored digital impression that you made or that we made from a stone model, and then we'll print models like this and then thermoform onto this and then send you the new appliances. So this is what a 3D printed model looks like, and it comes with their articulator, and all in all works very well. There's a different level of resolution in this accuracy done on the prep side versus the opposing side, just in terms of speed and efficiency, but we're able to work with these models well. So it looks and feels a lot different than a traditional stone model, but we have noticed that the accuracy is very close, if not to almost exactly the same, because you don't get the same type of shrinkage that you get from a polyvinyl impression and then subsequent expansion of a die stone when you print with 3D. So there's kind of fewer errors with this, but to a dentist like myself who grew up with stone models, these always kind of feel lightweight and never seem like you can really see detail quite as well as you can on a stone model. The interesting thing here, though, is that when we took the doctor's digital impression, which we received in addition to the physical bridge that came in, we realized that there was not enough room here for this bridge, specifically on the most distal abutment, so on this tooth right here. And when we measured it, when we measured between the prep and the opposing tooth, 0.42 millimeters. And so most of the newer versions of intraoral scanners, including 3M's newest True Definition, will allow the doctor to see this in the office. So this doctor did not get an opportunity to see this, did not know that he did not have enough room for Bruxer solid zirconia here, which is a minimum of 0.6 millimeters. And as a result, sent this to us and paid to have the model printed, even though we don't have enough room here. And when you can see this amount of under reduction chairside while the patient's there and the patient's numb, this allows you to go back in and prep more on the tooth or prep on the opposing tooth if you wish, and then grab another image right here and be able to see whether or not you've accomplished the adequate reduction, because at this point we don't have enough room to actually do a Bruxer bridge. And if we look at the model and zoom in on this a little bit, you're going to see some issues we have. We have a very short distal wall. And so if you look at the distal wall, and this is always very difficult to do because you can see how tapered it is, and it's almost impossible with the size of the head of the handpiece to be able to get back there and prep that distal wall well. It's a very big challenge and almost impossible to do. Sometimes it's because of the tissue that's back here, but whenever you see an over-tapered distal wall like this one, it's because of the difficulty of getting the head of the handpiece and the burr back there. And as a result, we have a very short, over-tapered, non-retentive wall here. So it's going to be difficult for us to do a reduction coping. Theoretically, like for example, if we were short on space on the bicuspid, we could do a reduction coping for the doctor, make it on here and send it to him and have him adjust that prep. But to do it here, we're just going to blow out that whole distal wall. And so a reduction coping is really not going to work here. In an ideal world, this tooth would probably have crown lengthening, yes, where a periodontist, so the doctor would go in and remove some tissue, drop the bone down, so we could get a little more room. The farther the tip of the burr goes subgingivally, the more straight up and down we're going to be able to hold that burr and get a better wall. This is essentially a non-retentive surface here. We're not getting any retention here on the distal of this lower second molar. The other way to create some more room here for a zirconia bridge would be to adjust the opposing, but you can see this crown, this second molar, looks like it's already been adjusted and then adjusted a little bit more compared to, say, the crown in front of it. So this appears to be something that's already been ground on a lot, and maybe that happened during this prep, or maybe it happened before, but it looks like we probably don't want to do much more adjustment on that crown. We could be wrong. We're going to have to call the doctor on this case, but really the two possible scenarios would be to do a little more reduction on this opposing tooth to get enough room, to perhaps have some crown lengthening done on this tooth to be able to reduce a little bit more but still have a somewhat retentive wall on the back, or to leave things as they are with our 0.42 millimeters of reduction here and switch this patient from a Bruxer bridge, which is not thick enough here. We'd have to go to cast metal here and a PFM bridge the rest of the way. So essentially it would be a PFM bridge with a metal occlusal, or maybe an entire metal abutment on this most distal abutment. At this point, metal is the only thing that will be able to stand that less than half a millimeter reduction. It certainly is not going to work for solid zirconia, so it would have to be a PFM bridge. And actually, when you see how non-retentive this distal wall is on this tooth, getting a zirconia bridge to bond to this and stay in place might be difficult too. So you're actually probably better off with a PFM bridge here, because you can bond to that non-precious metal, the substructure of the bridge, much better than you could to the zirconia and get a higher bond strength. And so the PFM bridge may end up actually being the better idea in a case like this. But of course, the best case scenario of all would be the dentist's ability to be able to see this under reduction while the patient's still in the chair, still anesthetized, and be able to make an adjustment on the fly before ordering the model and paying for the model and sending it to the lab, Now, if the doctor chooses not to do that PFM bridge because the patient wants something tooth-colored, patient's going to have to be brought back into the office, re-anesthetized, have some re-prepping done, maybe even some crown lengthening, and it's just an extra appointment for the doctor that's basically going to destroy any of the profitability associated with this 3-unit bridge. So the newer generations of digital scanners do allow you to see this before it goes out to your laboratory, and this is crucial because you can correct it at that first appointment and not have to have the patient back again, with which the patient isn't thrilled with, and which, as I just mentioned, destroys most of the profitability associated with these cases.
Thank you for that, Dr. D.
Thank the fine doctors of Glidewell who so willingly allow their cases, unbeknownst to them, to become the case of the week.
With that, let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from South Salem, New York, from Dr. Joseph DeLappa, and he writes, "Hi, Dr. DeTola and Megan. After watching episode 139 of Chairside Live, I wanted to tell you what I do to remove a cemented implant abutment or even a post and core from an endodontically treated tooth. What seems to work for me all the time is placing the cemented restoration in my toaster oven at 450 degrees for 10 minutes or more, then remove and allow to bench cool. Once cooled, the abutment or post can easily be pulled apart with a pair of carbide-tipped hemostat pliers using a minimal amount of force. Most of the time, pliers are not even necessary. Hand pressure is all that is needed. I have never damaged the crowns or abutments doing it this way. The post and core will have to be remade if it was not a solid cast post and core. Try it. It works." And he also writes, "Also, I want to thank you both for your weekly Chairside Live shows, which are always interesting, entertaining, and sometimes mind-boggling. I look forward to your broadcast, so please keep up the great work." Thank you, Joseph.
Well, Joe, thank you for that great tip. Megan, I don't own a toaster oven, and I haven't had one since college.
Okay.
So this seems like it's a good time. Today is Amazon Prime Day.
It is.
Hashtag Happy Prime Day.
Okay.
And maybe this is an option, a chance to go out and get another toaster oven, because I don't think I held on to the one from college.
I love toaster ovens.
When have you used one? Do you use one at home?
I do. I like when, instead of heating up the oven to make like a pizza or whatever, you can just do it in there. I just like, and then you could even.
Are we talking bagel bites, or are we talking like a full personal? What are we talking? A slice of pizza.
No,
oh.
I'm talking about like a Trader Joe's frozen pizza.
You have a toaster oven big enough that'll fit in there?
It fits in there anyway because their pizzas aren't like huge. They're just like, 2-person size.
My memories of toaster ovens are you couldn't fit anything more than, say, a Hot Pocket.
Yeah, no, they're pretty big, but they're not like too cumbersome.
Right.
Anyways, this is not about toaster ovens, but yes, you should get one.
Well, no, this is about Joe sliding his calzone over, as we Italians are apt to do, and then putting a crown that's got a cemented post and core in there. Or this was kind of what we were talking about with Josh Austin's case, where he cemented something on and then it wouldn't fit, how to get those back out of there. And what Joe is saying is 450 degrees in a toaster oven for 10 minutes, just plop it in there, let the cheese drip down onto it until it just starts to bubble, and then take it out and let it bench cool. And he's saying with at most hemostats or even barehanded, you can do it. So at 450 degrees, for 10 minutes must degrade the cement enough and break it down without causing any damage to the restoration, so you could just take it apart by hand and do that. That's a neat idea. The last time we've really seen toaster ovens in dentistry was Coltine, a group where a Swiss company that has a couple ex-employees that now work here. Okay. They used to go around and have dentists make like inlays out of composite and then put it in the toaster oven to cure it, and then cement it into the patient's mouth. And that was really the last time I've heard toaster ovens in dentistry, and haven't heard a lot more about that. But that's interesting that Joe brings up yet another use, perhaps, for toaster ovens in dentistry. So if you have a toaster oven, don't throw it away. If you're putting one of your children through college and they just finished and they graduated and they're about to throw away their disgusting toaster oven, no, don't. Bring it into the dental office and use it in case you ever need to separate something like a crown from either an implant abutment or from a cast post and core. It's really a great idea, because to try to do it with a handpiece would be really, really difficult.
And you can make your lunch at the same time.
Exactly.
It's a twofer.
Exactly. Make lunch for the staff as you do that. Put the crown and the abutment in there, slide in the bagel bites,
Awesome.
Here you go, staff. Lunch is on me today. I know it smells a little like dental cement and tastes vaguely of eugenol, but enjoy your lunch.
There you go.
Any news today?
Yes. A new poll reveals that 1 in 7 children in the UK have not visited a dentist by the age of 8. The findings come amid growing concern about Britain's sugar consumption. The British Medical Association called for a 20% tax on sugar drinks, but the government ruled it out. Later this week, public health officials will deliver their own review of sugar, which could call for changes in taxation, and will also decide whether the standard portions of sugary snacks should be reduced. Meanwhile, dental problems are the most common reason for kids between the age of 5 and 9 going to the hospital in England. The Royal College of Surgeons recommends that parents supervise their children's brushing until age 14.
14?
14.
They're almost driving by then. At first, I thought the story was 1 in 7 British don't go to the dentist before the age of 80.
Right.
But it was actually 8. Hey, look what I found.
What?
The toaster oven right here in the Chairside Live studios.
Yeah.
It's been kept. You might wonder why it's so clean and looks like it's new out of the box. That's the Glidewell marketing department. This is how they roll. I'm afraid to touch it without gloves on because I think I can see actual bacteria and perhaps a few viri walking around. But Joe, since you inspired me, I can totally imagine pulling, a dental. Oh, geez.
What?
It's done.
What?
It's done. Oh, and Joe, check it out.
In there?
Look what we cooked up for you.
So
Once uncontaminated, now probably should be autoclaved, a picture of Megan and I.
Yay, the Hot Pocket crumbs included.
And hot off the presses, a Bruxer adjustment and polishing kit. So just in case the toaster oven doesn't work for you, a couple burrs in case you need to cut through a zirconia crown. So thanks again, Joe, for that. I can't identify some of there appears to be a Dead Sea horse. And some other shriveled up things on the bottom may or may not be of this world.
Not sure about the rat feces either, but
right. This is. I hope Joe's is cleaner than this, and maybe you should just have a dedicated dental one without any food in it.
Sounds like a good idea.
As I go through these little crunchy remnants, hey, you like burnt ends? I remember you saying that on a previous episode. I'm going to find you one while you read this next story.
No, thank you.
Go ahead.
Okay. A Michigan man with lower back pain was told he had blood cancer and was given chemotherapy and radiation, even though tests showed he did not have cancer. The patient also was misled on the side effects of one of the chemo drugs, which is bone death, typically in the jaw. He says he has 1 tooth left and that he had to have pieces of his gums and teeth removed. Federal prosecutors said the doctor raked in millions of dollars and had more than 500 victims. The doctor pleaded guilty and is currently in court awaiting his fate. Prosecutors are seeking a 175-year sentence.
That's an awful story. Did they mention what medication? Was it a bisphosphonate? Did they mention what kind of medication it was in the story?
I think that they said the name, but I can't recall it at the moment.
What
are you doing in there?
I see something that I think used to be a French fry that I'm trying to get
I don't
for you.
really want that.
This is, are you familiar with Newport Beach barbecue?
No.
It's not Texas barbecue. So, okay.
Seriously, that is so gross.
Look, $50 or a bird kit. Identify this. You're not allowed to use your fingers. Simply your nose.
I know exactly what it is.
What is that?
That is a piece of burnt cheese from someone's pizza that has pooled and hardened.
It smells more like an earlobe.
Okay.
No,
I don't want to smell it. Thank you, though.
You don't want to know? Anybody who can identify this or is willing to, let us know. We'll send this out to you. You can carbon date it. It looks like it's from the Pliocene era. And I don't know how long it's been in there. You think it's cheese?
I think it's cheese or some sort of pizza topping.
All right. Well, I'm not sure. I'll tell you what, it's not.
Don't touch anything now, please.
I know. I'm absolutely filthy. Joe, look what you've started.
Okay, can we talk about this story?
You derailed the show. Go ahead.
No, I already read it. Let's talk about it. So this guy, gets how scary to be diagnosed with blood cancer, told that this certain medication has no side effects, and then you have to have some of your gums and all your teeth except one removed.
Right.
Now, important to note that during cross-examination, the victim did acknowledge that he has had long-standing dental problems, but that he would leave it up to an expert to identify if there was any relation between, you know, something that would have happened maybe from the drugs or if this was, you know, a pre-existing condition. But all that said, this is terrifying.
Right.
How did this man get, he was able to take millions and millions and millions of dollars in Medicare, Medicaid, whatever, fraud, and then victims, 500 at least?
Your Honor, I'd like to introduce Exhibit A for the jury. My client, this was a perfectly good tooth 3 weeks ago. This was a lower first molar. And men and women of the jury, I ask you, why should my client have to deal with this?
Oh,
men and women of the jury, I've cooked up some delightful treats for you now. I'd like to offer you some Hot Pockets.
Are you done yet?
No, I don't know.
Seriously, it's just, Joe, look what you did. You created a monster.
I didn't know we had a toaster oven in there, and I didn't know it was disgusting.
It's like a child.
I didn't know my fingers would be this sticky either, for God knows how long. Well, thank you, Joe. That about wraps it up for this edition of Chairside Live. Time to close the old door on the toaster oven. On behalf of all of us here at Glidewell, CSL, myself, Megan, and the whole crew, we want to thank you for your time and your continued commitment to quality dentistry.
Send help.
On today's case of the week, digital technology. With that, let's go to a segment we call Oops, You're the Case of the Week.
A new poll reveals that 1 in 7 children in the UK have not been vented. Sorry, and it was moving quick. The point is that it's disgusting. Seriously though, I think a bird pooped on the back of it, and I'm not sure how that happened.
I feel a segment coming on where every week we reach into the toaster oven and pull out a prize. 1 in 7 British don't go to the dentist before the age of 80.